Okay, now we can't see anything.
Will be only me and you.
I can see you. Okay, we wait some for participants who are already in there. We wait some more like 30 seconds, a minute to allow people to get into the webinar before we start. So we're just gonna look to the numbers. When they start to stagnate, we can start. Okay, I think people which are coming in are stagnating now. I think we can start now. So good evening, good afternoon, or good morning, wherever in the world you are. And welcome back to the EANS webinar of the spine section. This is now the restart of the spine section webinars after the summer break. We're starting now late summer, autumn webinars again, and we'll have another series of events. So today's webinar is focusing on one hot topic of enabling technologies, which is discussed during many meetings and is gaining more and more interest in the treatment of spinal pathologies. And I'm very happy today to have here with me a very well-known spine surgeon and close friend of mine, who's Enrico Tessitore. He's a professor of neurosurgery and spinal surgery at the University of Geneva. It's very active in scientific questions of spine surgery and how to advance spine surgery. And today, Enrique is going to talk about these enabling technologies, augmented reality and virtual reality, how they can be integrated into spine surgery and what benefits those techniques bring to a spinal surgeon and to several different pathologies. I'm happy that you're here tonight, Enrico, and the stage is yours. So please, we're looking
Great.
forward to your presentation.
Thanks a lot, Florian, for this kind introduction. I hope that you might see my screen. So
Yes,
it is a
very
pleasure
nicely
to...
visible.
Good. It is a pleasure to be tonight at the ENS Spine webinar. And the topic of today is the augmented and virtual reality in spine surgery. No longer that few days ago at Eurospine Congress, together with Florian, we did animated a lunch symposium where this was one of the topics. So it is very fancy now, and I think there is a potential utility and a big application in the field of the spine surgery. So these are my disclosures here. So what is augmented reality indeed? Augmented reality is where a computer-generated image is superimposed to the surgeon's view of the real world, making and providing a composite view. While virtual reality is where the computer generates a simulation of a true environment that the user can manipulate with the help of specific tools. Today in spine surgery, we often talk about mixed reality, where the digital and physical elements coexist, and that can be manipulated some way by the surgeon. Of course, there is a big evolution upon time about this technology, and after the era of navigation and robotics, we are entering the era of the augmented reality. You might see some few introduction names here of augmented reality and virtual reality tools, which have been approved by the FDA, and we will discuss some of them during the presentation, with a very big market value, at least estimated at 2030. Here again a list of the most common, and in green one, that's what we will discuss today. This is part of the evolution of the technology and enabling technologies in order to improve visualization, not only, but also accuracy and safety in our very challenging field. And very often it goes together with the navigation and sometimes with the robotics. Why do we need augmented reality in spinal surgery? We know that the depth of surgical field and lack of visualization of hidden targets are true challenges in spine surgery. And apart from enhanced visualization, there is also need for having a tool helping in planning, tool for education of young surgeons, or for even single procedures. And last but not least, the use of implementation of this technology might facilitate the concept of minimal invasive surgeries, as demonstrated from some papers. Here, for example, a paper where the MIS is associated with the use of microscope-based augmented reality. And we also have some futuristic application or some sort of realistic application nowadays, like the remote assistance, where the mentor himself or the trainees might be in remote and might assist or look at some surgical procedures, and might also might be placed for an interaction remote with a specialist for some specific or difficult cases. How we do implement it? We do have several options and interfaces together with the navigation, which is one the projector-based, the monitor-based, the Microsoft-based, and head-mounted displays. So the projector-based are very rarely used nowadays. There is an additional hurdle of knowing the relative pose of the capturing and projecting devices. So I would say it is almost abandoned, but I would say that the most commonly used augmented reality application in the spine surgical field is the monitor-based, where we are able to inject and superpose computer-generated images on monitors, which are commonly the monitor of navigation, with, of course, cameras and camera tracking system. The microscope base starts to be used also in some specific field, especially for spinal tumors, and again, in combination with the MIS concept or tubular approaches, where the microscope is brought in the field and the computer-generated images are injected into the microscope. There is a big interest about head-mounted displays, and there are many that are already FDA approved, where the digital information is superimposed onto the real-life object, and the surgeon is wearing these displays and glasses, and this is an application, a kind of mixed reality application. And we discuss some few cases and few implementations. Here, the advantage of having glasses or the microscope itself, that there is an avoidance of a line of sight interruption, which is required by, in contrast, by the monitor-based augmented reality, where there is a switch of attention from the surgeon, from the surgical field to the monitor itself. So this is a big advantage of microscope-based and head-mounted displays. No matter which kind of augmented reality tool we do use, there is common workflow. The first one is, of course, patient registration. There is an intraoperative acquisition done by cone beam CTs or 3D isocentric arms with simultaneous patient position registration, or sometimes we might use also preoperative CT scan or images or MRIs merged together with CT scan, and we perform what we call the region matching, with the goal of align the radiological imaging with the patient in operating room. The second step is tracking. The tracking is obtained in most of the cases by infrared cameras with optical fiducials attached to the patient's skin or attached to a reference frame on a spinous process. Or there is also the possibility to do a direct surface matching and tracking without or with adjustment manually done by the surgeon. The third and most important step is, of course, the injection or the superposition of the computer-generated image on the microscope or into the microscope or into the head-mounted displays, like you see on the left. And there is an integration into the AR device, and the superimposition should be perfectly overlaying the two images. Otherwise, it won't be reliable, of course. What is the evidence in literature about the implementation of augmented and virtual reality in spine surgery? There are few lab studies that worth some mention. For example, here, a study from the group of Terander using the Magic Leap from Braille Lab in a hybrid OR setup. The software is doing the merging between the real CT scan and the computer-generated images. And there is a need for overlaying of the reference array and frame with what we see here in green, the green balls. So the reflective spheres are perfectly overlaying, otherwise the technology won't work. And of course, there's been a preoperative CT scan done with cone beam CT, creating at the end a 3D model of the spine. So in this specific study, they evaluated the feasibility and accuracy of thoracolumbar pedicle screw insertion, and they inserted 48 pedicle screws. And if you might see, if you see look at the Gertzman-Robbins accuracy scale and grading, 45 out of 48 were graded 0 and 1, which is more or less aligned to the results in terms of accuracy of the standard technology that we have available nowadays. This is another cadaver lab study, which is done from the group of Zurich. And here they compare the freehand technique versus the augmented reality assisted screw placement with the help of HoloLens. And they calculated the deviation from of the executed entry point from the planned point and the deviation of the executed trajectory from the planned trajectory. And here the results, they of course did an acquisition with cone beam CT, with the planning, and they used the navigation to insert K-wire, either with freehand or either assisted by augmented reality. And the augmented reality in this series improved the trajectory angle significantly. In contrast, the choice of the entry point wasn't different in between freehand and augmented reality navigation system. This is also a very interesting study, concluding that the technology is reliable and operator independent, in the sense that in this study from the same group from Zurich, they compared the performance of two biomedical engineers without any surgical or anatomical education with two experienced spine surgeons. And in terms of accuracy of vertical perforation, there was no difference between surgeons and what we call the laymen, with a slight significant tendency in favor of surgeons when it comes to numbers of points required for the registration, where surgeons were better than laymen, and also for the bending of the rod with the help of the augmented reality, the surgeon was superior to the layman, at least for the first bending. So you might see here, probably the augmented reality is some way compensating for potential skill deficits. I won't say that this tool would transform a layman or a biomechanical engineer in a good surgeon, but at least it might probably bridge the difference. And the same is valuable, of course, for youngest surgeons in training. What about the clinical evidence? There are a lot of studies on augmented reality implementation in spine surgery. Some of them, again, they evaluated accuracy of screw placement. Some of them evaluate the surgical time or the radiation exposure or the surgical outcome. And then we go through some of these studies, and I did separate according to the indication and to the disease itself. So at the level of degenerative spine, when it comes to accuracy for screw placement, here there is a study from the same group of Terander comparing augmented reality navigation, a monitor-based augmented reality navigation supported by Philips Allura, to the free-hand technology. This was the workflow, and if you might see on the monitor, there is a computer-generated image like bull-eye view here, or a blue line, which is the ideal linear trajectory of the drill itself, which is then followed on the monitor by the surgeon. And they compare 20 cases done by augmented reality with 20 cases done in freehand. And this was around 260 or 280 number of screws, which were rated, and according to the Gertmans-Robin scale. And the primary endpoint results are the following: that the clinical accuracy of the augmented reality group was significantly higher compared to the freehand group. And the proportion of grade 0 screws was twice as high in augmented reality group compared to the freehand group. This is a study implementing head-mounted displays, which are the X-Vision from Augmedics, for insertion of pedicle screws. You might see here the surgeon wearing the glasses and watching the computer-generated images. You might have some dedicated tools with trackable stars and tools attached to the devices and to the screwdriver. And of course, this is done after acquisition, intraoperative done by OR Mozim, and the registration done by the surgeon. And the registration frame was exchanged with a tracking marker, which was opposite to the surgical field, to the surgical site of insertion. The screw accuracy was elevated, very high. You might see 98% of screws were grade A or B, according to Gertmans-Robbins. So this technology is reliable when it comes to screw accuracy in a big series of 205 screws. What about surgical time? One of the criticisms advanced to this technology is that it's adding a lot of time to have a surgical procedure, which is true at least at the beginning, in the sense that we need a learning curve. And you might see here in this study on 6 pedicle screw inserted by experienced surgeons, that the mean time per screw was, of course, higher for the first 20 cases, but it was improved after the first 20 cases. It dropped down to 3.5 minutes per screw, which is a reasonable time when you are implementing a new technology. Of course, this technology requires a learning curve. Here, a nice study from Barbara Kao about accuracy and radiation dose in 10 cases, which was at the thoracic, at the lumbar level, and for different indication. Here, for example, a thoracic disc operated with the help and assistance of augmented reality. You might see the disc hernia in blue superposed to the microscope view. And they measured the target registration error, which was very low, very often lower than 1 millimeter. And of course, the effective dose provided by the low dose CT protocols to acquire the images was much lower, at least 1/3 of a standard diagnostic spine scan. I don't have serious about the augmented reality in vertebral augmentation, but I just want to share with you our experience already in 2005 with the Philips Allura monitor-based augmented reality to guide the procedure, percutaneous procedure like balloon kyphoplasty. Here you might see the X-Persity done with Philips. And we see the fracture, of course, and we did plan an ideal trajectory to get into the pedicle and to perform the kyphoplasty. You might see that this ideal trajectory is indicated by a laser. This is done, of course, on a saw bone before going into the real implementation. And the needle, the Jamshidi needle, is following the laser according to the ideal trajectory planified by the surgeon. And we were able then to see on the monitor the true advance of the Jamshidi needle and the key wire into the vertebral body, and the superposition and the merging with the computer-generated green image and ideal trajectory, which was very reliable. And we did some few cases with success. What about tumor removal? I do think that the augmented reality is extremely helpful for very specific cases. And I want to share with you our experience. Of course, it's not only our experience, it is also experience from literature. For example, Roger Alter has already published very nice papers on the implementation of AR microscope-based in the resection of dural extramedullary tumor, for example, here, where the tumor in blue is superimposed into the microscope, and it might be very helpful to limit the bone removal in order to access to the tumor. You might see also the different steps of surgery, which is what is our experience about microscope-based augmented reality. This is a case from the cervical case series here, osteoid osteoma, the lateral mass of C7. And again, this was navigated by Braille Lab, and the microscope-based augmented reality used to superpose the osteoid osteoma in red to the normal bony anatomy, allowing for a very limited resection of the lateral mass of C7 and preserving the stability at that level. Another case of a patient with a fibrous dysplasia and a pathological fracture of C2 odontoid peg here. The biopsy was done with the CT scan in another institution, and you might see from the MRI the involvement, encasement of the left vertebral artery at the level of the V3 segment, and of course the PET-CT scan here. We did implement a microscope-based augmented reality after exposure. You might see the merging of the fake to the real image, and perfect overlaying at the level of C1, C2 posterior arches. And we segmented the vertebral artery on the elements viewer of the Braille Lab the day before. So we knew from the beginning where the vertebral artery and the V3 segment is located. You know, this is a segment which is not protected by bone, very delicate and dangerous to go there. And we went through the pedicle to resect part of the dysplasia very safely. You might see the correspondence between the true artery, the skeletonized artery, and the computer-generated images. And at the end, the surgery was safely performed with fixation C1 down to C3. We already mentioned this case in our book on the crâniocervical junction. This was a neuroenteric cyst of a 70-year-old patient presenting with limited motion in the neck with pain. and the MRI and the CT scan show a compression of the spinal cord behind the transverse ligament. And here you might see the intraoperative merging of the real occiput, C1 and C2 posterior arches with the computer-generated images. And you might see the correspondence between the yellow spinal cord, which is injected into the microscope, and the true spinal cord after resection of the neuroenteric cyst. This was done, of course, after labeling, after the automated segmentation the day before of the tumor itself in blue, the spinal cord in yellow, and the vertebral arteries in red. Here are some complex cases at the level of the sacrum, where I do find the monitor-based augmented reality extremely helpful to achieve and block resection, safe and block resection, and stabilization if needed. Here, for example, a case of chordoma, and the DTI MRI was used to identify the lumbosacral plexus, and these images were used to build a sort of a virtual pelvis. You might see here on the Elements viewer software, you might see in green the lumbosacral plexus, you might see the iliac vessels in front of the sacrum, in violet, you might see the rectum and the bladder, and of course in red, the tumor itself, and in blue, the biopsy tract that we decided to excise it at the time of surgery. The surgery was scheduled in 2 stages. The first one was an anterior approach done by our general surgeons, performing what we call an anterior release of the tumor and protecting the vessels and all the very important structure in the pelvis. The second stage was done by us. The second day, you might see here the surgical planning, and we first did an acquisition with a reference on the L5 spinous processes. These allowed us to recognize the biopsy tract at the level of the skin, and you might see that the biopsy tract was excised together with the surgical piece. And at the end of surgery, you might see the tumor is out. This is the colon here, and the 2 sciatic nerves, S1 nervus for both sides, which were preserved with a marginal resection or near marginal resection, and the stabilization of the pelvis was obtained by navigated iliosacral screws. Here, a second case of sacral chordoma going up to S2, S3 level, that the biopsy was confirmed under ultrasounds. And here you might see the reconstruction of the pelvic virtual pelvis, and very helpful to perform the resection of the tumor, respecting the pseudocapsula and the borders of the tumor itself, and also doing a safe osteotomy in order to preserve the S1 nerve roots bilaterally with navigated osteotomes here, and this was done safely. Again, recurrent rectum cancer, operated several times, radiated already, and invading the presacral fascia here and the sacrum in the lower part of the sacrum here. You might see the PET CT scan. And again, we did use the iPlan software for the virtual pelvis, and we did perform a safe osteotomy, which was a mid-sacral osteotomy, and the pelvic exenteration with the help of our general surgeons. Here you might see the cut at the level of the sacrum and the surgical piece together with the skin. So I'm approaching the last 2 slides. There are some limitations in implementation of this technology. The first, of course, is the cost. This technology is nowadays, unfortunately, still very expensive. So we do apply this technology. We do have available here in our hospital, and many hospitals, I would say, in the center of Europe, but it is not available in all the centers. So again, the idea is to implement if available, and I think that the costs and the money injected in this project might be very helpful to increase the safety of our surgical procedure, especially in this kind of big tumors. There is, of course, a learning curve. There is a learning curve which is very fast, I would say, for monitor-based augmented reality, which is a bit slower, I would say, for microscope-based. But as neurosurgeons, we use microscope since the beginning of our training. So injecting the computer-generated images is not a problem at all. There is, of course, a necessity and time for registration and recalibration in OR, because there is a must for a perfect overlay of the computer-generated image and the real world. For monitor-based augmented reality systems, the attention, as I mentioned before, sometimes shift away from the operative field, which requires, again, to go back into the operative field. This takes some time, but it is, of course, feasible. For wireless head-mounted displays available nowadays on market, charging may become problematic in longer procedure. Ergonomy might be an issue. Some of them are very heavy. I've tested them, and some of them, they have a charging cable, and so ergonomy is very important in our profession, in our job, especially for very long procedures. So take-home messages is that the augmented reality is a reliable and effective support to spinal surgeons, providing automated preoperative planning, better intraoperative visualization, a targeted route to the lesion, and this is extremely valuable in the setup of a minimally invasive concept. Improving outcomes by reducing the risks in complex cases, like, for example, in block safe resection of very big tumors, respecting the normal vascular and nervous structures, of course. But at the end, augmented reality should not obviate, of course, the need for a fundamental understanding of the surgical anatomy. Thanks a lot for your attention.
Thank you, Enrico, for this very nice, comprehensive presentation. So for all participants, if you have any questions, please type your question in the Q&A box, and we can read it, and we will discuss the points you bring up. So if there's anything, type it in. I would like to start with some questions from my side. I mean, you nicely showed how this evolved and what the current applications of augmented reality are. And you showed those studies looking at accuracy, looking at radiation exposure, surgical time. But the majority of those studies did compare augmented reality versus the freehand approach for the placement of pedicle screws. So I think that the majority of benefits you get in those studies is by the integration of navigation. But we don't really know about the added value of augmented reality to whether you do navigation only or you do navigation plus augmented reality. Is there anything available so far? And I would expect that it's more about surgeons' convenience and workflow, making it easier to have the navigation data readily available without using the pointer for many times.
Absolutely right. I mean, I do agree with you. Probably there is a sort of over skills of this technology when it comes to inserting pedicle screws. And the first studies that I have shown are mostly based on the concept of feasibility, safety, and to see at least if the technology is comparable to the standard techniques available, which is freehand or navigation itself. I don't think there is a big add value to implement the augmented reality in screw insertion, honestly speaking. And this is the navigation making the difference, as you are pointing out. But if you don't start to use for simple cases, and then you want to start to use for complex deformity where you might have rotational vertebral body. You want to see the rotation on a monitor based or microscope if you use it. Probably it is helpful to have already done the learning curve on simple procedure, which is thoracolumbar pedicle screw insertion. I think the add value of the augmented reality is nowadays more in tumor surgery than in degenerative stuff.
So how in your practice, what do you use it for, or how often do you use augmented reality now? Do you use it for many degen cases as well in order to increase your experience and get the workflow better, to have it available for those cases where it's more mandatory or where it's more not let's say mandatory, but probably more helpful and does add more value, like in the tumor cases you mentioned? Or do you use it now for selected cases like the tumor cases?
I do only use for selected cases. I do not use for degen stuff, but I do use for microscope based for spinal tumors and the monitor based for big sacral tumors, for example. This is my experience nowadays.
Okay, good. Now we have some questions, but the first one is about thoracolumbar pedicle screws are the easiest spinal instrumentation procedure. It's not a bit of an overkill to use these technologies for this? Don't you see more potential in complex deformity in tumor cases, and is AR, VR consistently accurate for this? You answered this already, but
I think I answered already. I do agree. This is a sort of overkill, very expensive overkill. But again, I mean, if you master technology, then the learning curve will be shorter and implementation in complex deformity cases will be much straightforward. For you, it's for the surgeon and for the OR staff as well.
But now you said it's an expensive overkill. I mean, if you use navigation for your classical thoracolumbar pedicle screws, well, what else is there as additional cost for the individual case? I mean, well, what you need is when you want to use a head-mounted display, you need to invest in this once, but there's no additional cost if you use navigation anyway for the individual case, or
you're right. I mean, head-mounted displays, they cost a lot. And there is some software that you might need to how do you say, improve the navigation software in order to have monitor-based stuff, which is mostly a software with automated segmentation, automated labeling of the vertebra, automated recognition of anatomical structure like vessels of nerves. So this is some software you might integrate to the already existing navigation for pedicle screws.
Okay. Now, next question from the Q&A box. How often should you verify the accuracy of AR during surgery, and what is your workflow if you notice it's inaccurate? So it does as well as the question, how often is it necessary for navigated cases?
Of course, we do check the accuracy at different steps of surgery. The first one, the most important one, is at the beginning. For example, when I bring the microscope in, there should be this perfect overlay between the true reference frame and the virtual reference frame. If I don't have a reference frame available into microscopic view, like, for example, I did for this crinocervical junction case, we might rely also some skin fixed anatomic landmarks that you might overlay to the normal anatomy. So if you don't have a reference frame available, we do check on the skin of the patients with some fixed point. Then, of course, we start the procedure, and I would say with the help of navigation, we do a double check the accuracy of augmented reality image very often.
Good. Good question. Would you acquire a robot or AR if you had to choose? Or maybe you can comment on robot versus navigation, where you see that. Maybe you use both. You have a robot now.
I had and I will have.
Okay.
In meantime, I use a lot the navigation. So we didn't, of course, I didn't mention the robotic technology because I do not have seen or any implementation of augmented reality together with a robot. But if you're asking me if a robot is essential to insert screws, probably the answer is the same. It's an expensive overkill to insert a screw in a thoracolumbar level, but probably for a specific distorted anatomy revision cases, very small pedicles or pedicles into deformity, having a robotic stiff arm might be of some help. And if I had to choose, I would ask first to my administration how much money do I have, and then I will choose. Because the price is not the same. I mean, the cost is not the same. A robot and augmented reality tool.
Let's say you have no navigation, you have no robot, and you're given the amount of money you need for a robot. What would you acquire first? Would you then go for a navigation system, or would you go for a robot?
I would go first to a navigation system, because I would use it much more often than a robot.
I think it's the advantage is much more versatile to have a navigation system.
Absolutely.
I mean, the robot is just for placing pedicle screws or placing screws in historical lumbar or cervical spine. But all the options you showed now, whether you're navigating a tumor with augmented reality, or you're going for you're predefining in your tumor planning, which you can say somewhat like virtual reality, a resection plane is possible with navigation, but it's not possible with a robot. Therefore, I think if I had to choose, I get the money like 1.2 million, and I have then none of both. I would go for navigation first, and I think the robotic is opening another door and potential things evolving. But for the time being, the navigation is much more versatile and better to use, and that as a broader indications than the robot.
And it's also a better tool for education. I mean, we are working in academic places, so we do education, and having a navigation is fantastic. I mentioned these hidden targets beyond the posterior arches that we don't see, and then when we do apply the pointer with navigation and or augmented reality, we do see through the vertebrae, and we do see the anterior body, we do see the tumors. So for educational tool is a very good tool.
Okay.
Educational purposes.
So we have one more question. It's about how do you manage the 2D acquired images from pre-op into the 3D environment of the microscope, especially in the overlay?
Very good question. So we do acquire 3D images, which is either with a cone beam or with isocentric 3D C-arm. So these 3D images are sent immediately to the navigation software. We do use a curve navigation software from BrainLab, and they can be either visualized on a monitor. So this is sort of a monitor-based augmented reality if we then inject some other computer-generated images. Otherwise, there is a specific software allowing for superposing the acquired images into the microscope, or the images that you have segmented automatically the day before, the region of interest, some anatomical structures, or the tumor itself will be automatically injected by the software into the microscope. And you check about overlaying of the computer-generated image and the true world. I hope that answer to the question.
Okay. Well, we just get one more in. How do you feel about losing the haptic feeling in spine surgery with using and relying explicitly on visualization in AR and VR?
I don't think I'm losing the haptic sensation. I do rely a lot on my haptic sensation. I love to close my eyes and to use just 2 fingers or 3 fingers to advance a pedicle screw. Of course, I keep my eyes very open when I do drill some bone around the nerves. I would say that haptic sensation probably won't be replaced by augmented reality. Probably the question is more What about haptic sensation in robotic spine surgery, where you have this solid arm and you get with the drill inside? Of course, drilling is done by surgeon, not by the robot. The drilling procedure, you might keep your haptic sensation to be sure that you are drilling to the bone and to double check the robotic arm position. So I think haptic sensation is essential. We need to preserve the sensation.
Yeah, and I think haptic sensation remains the same whether you go AR or not, and you're having the enrichment by further visual animation or sensation when you add the AR than without the AR. So you get one more quality of information you would not have when not using AR or have limited visual information. Okay. No more questions. Thank you very much, Enrico. Very nice presentation, very good discussion, I think. So for all of you, thanks for your participation. Thanks for the questions you asked. And we're coming back with the next webinar, I think in the next month, beginning of next month. We'll announce it in a timely fashion, and enjoy the rest of your day. See the majority of you hopefully in Sofia.
Thanks a lot. Thanks,
Have a good
Florian.
evening.
See you
Bye-bye.
soon. Bye-bye.